started just to sense who is who. How many are nurses here? And how many EEG techs? Just one? Two? Oh, there we are. Okay, good. Neuropsychologists and neurologists, and okay, and neurosurgeons. Good. And one final question, given the venue, who can name the songwriter that wrote Poncho and Lefty Made Famous by Willie Nelson? Was a troubled individual, you have to say, but his picture's on the wall out there, and he's one of my favorites. So I changed the title of this talk a little bit, and what I wanted to do is, can we go back to the title slide? Let's see, there we go. From a neurosurgeon's perspective, give a little bit about the history of how we got to where we are now. This next day and a half is going to be about where we are and where we're going. But I wanted to also give a bit of a more global perspective, and I'll let you know that I've spent the last 30 months working in St. Jude's global program, and we'll talk a little bit about international outreach as well. So what I want you to do is understand the differences between care provided in high-income countries like ours versus low and lower middle-income countries, some of the healthcare discrepancies, some of the workforce issues, and some of the things we could do to increase capacity to be able to provide better and more care to kids around the world. And I'll make the point that the world has become a smaller place, particularly since the pandemic, and that we all need to have a global vision when we look at what we do. So when we look back in antiquity, and I'll also make the point that our world is increasing logarithmically. For centuries, the world was relatively flat in terms of change, but now change is occurring so quickly we can no longer write textbooks because they're out of date by the time they're published. Remember that in 2007, Steve Jobs introduced the first iPhone, and at that time we had no such thing as apps, social media, any of that stuff that rules our world today. So when we look back thousands of years, epilepsy has been part of the written history of medicine forever. And even back in the time of Hippocrates, they understood that if you're going to operate on someone with seizures, you have to operate on the side of the body opposite the side of the seizures. And that writing spread around the world. It was translated by Arabic writers and went on to Europe as well. We often think of trephination as something that came from the Incas, but in fact, trephination has been done on every continent in the world historically, primarily for traumatic depressed skull fractures and things like that. But epilepsy was one of the indications for trephination in several cultures, and we know from these skulls that a number of them have healed bone edges, so obviously the patient survived surgery long enough for the bone to heal. There are a number of different techniques that were used in different parts of the world and a number of different instruments developed for trephination, but for centuries this was the mainstay of neurosurgery. In the Middle Ages, we started having more writings, oftentimes religious writings about people with epilepsy being possessed by the devil and such as that, and means of exorcising devils to treat epilepsy. I can tell you in my time as a neurosurgeon, which is relatively short, I've seen a 5-year-old kicked out of a parochial school because she was possessed by the devil with her epilepsy. I've had a 14-year-old who came to clinic with a hysterectomy because her parents didn't want her to pass her disease on. I've had a teenager who came to me from a psychiatrist after he'd attempted suicide because his family kicked him out of the house because he was an epileptic, had to move to the farm and live with his aunt and uncle. So it's not gone away. This is a painting from the Harvard Museum of John Clark and a trephination said to be the first in our country. So this is 1600s by then. But really, healthcare started to change in the latter part of the 1800s. And for those of you who want a good read, The Butchering Art is a fabulous book. It starts with Lister and goes through the history of surgery as it developed, and it's well worth the read. So in the 1880s, in 1886, working with Hewlings-Jackson, Victor Horsley reported doing epilepsy surgery in a 22-year-old who had a history of a depressed skull fracture, focal motor seizures, and gliotic brain underneath the depressed bone that they operated on with some success. And there may have been some surgeries done prior to that time. McEwen probably did some, but it's not reported such as an epilepsy surgery. I've put Halstead in here because he is a general surgeon who predated the subspecialty of neurosurgery, but a fascinating character. And I'll make the point that in America, in that time, people that trained in medicine would generally go spend a year or two in Europe looking at the European masters, watching how they did things, and then come back to the United States. And Halstead did the same. He went to Europe and spent time with a dozen different surgeons, watching them operate in different venues and watching how they did it. And in those days, there was no anesthesia. The patients were generally tied to the table and operated on. But his interest in cocaine that led to his lifelong addiction with the drug came from that background. As an intern in Columbia, he asked the nurses on the ward to start keeping a record at the bedside of his patient's temperature, respiratory rate, and heart rate, and was the founder of the bedside medical chart that we all use every day. He was one of the first people in the United States to perform a cholecystectomy on his mother on her kitchen table at 2 o'clock in the morning because she was septic from cholangitis. He was also one of the first people in the United States to give a blood transfusion. And the story was that he was called to labor and delivery to see his sister who had just given birth. And when he got there, he found that she was in hypovolemic shock from blood loss. So he pulled his shirt off and had them transfuse his blood into his sister and saved her life, one of the first transfusions. But he went on to be the first chair of surgery at Johns Hopkins, and he introduced to Hopkins a training schedule for surgical residents that we still use today. So a very famous guy. This is Krause, or Krause, as the Germans would call him. He was a surgeon in the 1880s. He wrote a first report of a laminectomy for someone who was paraplegic from Cauda-Equina syndrome and took a ruptured disc out. He also published one of the first textbooks on neurological surgery and was famous for a subtemporal approach to the Gasserian ganglion for trigeminal neuralgia. And then Harvey Cushing came along, born to a physician's family in Cleveland, schooled at Yale, and at his father's suggestion, he approached Halstead about training under him at Hopkins. Halstead said, "There's nothing great going on in surgery in America. Go to Europe for a while and see what the masters are doing there." So he spent time in Italy with Riva Roche, who developed the blood pressure cuff, and he came back and applied the blood pressure cuff during anesthesia through surgery, saving a lot of lives, keeping an eye on the blood pressure while surgeons operated. He also spent time with Coker in Bern in his lab, and they would do a craniotomy and put a balloon in and blow it up, and as the pressure increased on the brain, he would document the bradycardia and hypertension that became known as the Cushing reflex. But he's known as the father of neurosurgery in our country. And in 1918, at the American College of Surgeons, Dr. Mayo stood up after Cushing gave a presentation of a series of brain tumors and said, "Today is born the subspecialty of neurological surgery," after Cushing's speech. And he went on in 1920 to found the Society of Neurological Surgeons, which is our oldest surgical society in the world, neurosurgical society. And you can see the 12 founding fathers there, and then the picture on the right is them watching him operate. So in those days, if you were a member of the society, you would take turns going to each other's hospital and watching your colleagues operate, because they didn't have journals, they didn't have textbooks, so they would look at how you position your patient, where you make your skin incision, where you make your burr holes, how you drew the surgery, how you stop the bleeding. And I love the picture of the light bulb strapped to Cushing's head while he did his surgery there. So Van Wagenen was a trainee of Cushing's. He went to Breslau and spent a year working with Ottfried Forster, Breslau's former Prussia. And during that time, also worked with their pathologist and came to write a paper on the arachnoid cap cells being responsible for meningiomas, but also looked at the connections of the brain and came back and started doing corpus callosotomies for patients with epilepsy. One of the people who went to Breslau to study with Forster before Van Wagenen was a guy named Wilder Penfield. And at the time, Forster was doing awake craniotomies and stimulating the brain and recording the brain waves. And that's where Penfield developed the interest that he would take to Montreal with that surgery. So Dandy, Walter Dandy, also trained under Cushing. For those of you who've spent time in Memphis and know Sims Murphy Clinic, Dandy and Sims went to college together in Missouri. They got to be friends, decided to go to medical school together, and were roommates at Hopkins when they trained under Cushing. And at the end of their training, Sims came back to Memphis and started our clinic. Dandy stayed there. But Dandy started taking out half of the brain in patients with glioblastoma in hopes of curing them by removing this radical resection. And what they noted is that those patients who had seizures from their tumor had their seizures get better when they took out half their brain. And that led to this whole timeline of modifications of the hemispherectomy that started with Dandy and brain tumors. This is a picture of the founding of what was called the Harvey Cushing Society. Those who were too young to get into the Society of Neurological Surgeons decided to set up their own neurosurgical society, and they were afraid that Cushing would get angry if they found out they were making a competing society, so they asked him if they could name it the Cushing Society, and he was so delighted he housed the first meeting. But Van Wagenen was part of that. So some credit to Egan Moniz, who is the first person to inject contrast dye into the arterial system and make X-ray recordings, i.e. angiography. But interestingly, that's not what he won his Nobel Prize for. His Nobel Prize was for the prefrontal leucotomy for psychiatric disorders, and so he's worthy of mention. And then the Montreal Neurological Institute, and in the 1930s and 40s, the work that Jasper and Penfield did with awake stimulation of the brain, recording meticulously in large series of patients as they did their surgery what different parts of the brain did. And I suspect many of you in the room have read Penfield's book on that. One of Penfield's trainees was this gentleman, Herman Flanagan, who was my mentor. I think, Jim, he was your mentor as well. Herman did private practice in Oklahoma for a number of years, but came to the University of Arkansas when I was a student there, and even before medical school, trained me to be his EEG tech. And so I would go to the operating room, and he would put the wick electrodes on the brain and record, and then I would show it to him, and he would take out the part of the brain causing the seizures. But this paper in 1950 was their series of temporal lobectomies, and by the time they reported it, they had close to 100 temporal lobectomies. All they had was an EEG machine. They didn't have CAT scans, MRIs, blood tests for blood levels, any of that stuff. And their results back in the 1950s are not much different than our results today from temporal lobectomy. Just incredible, opening up people's heads without knowing what they were going to find inside. And I remember in Augusta one time him operating on a teenager based on, this was CT era days, temporal lobectomy for epilepsy, and getting into the hippocampus and saying, oh, there's a glioma. This kid ought to do great. And we didn't know it was going to be there till then. So, the world in our perspective. As you can see, the population growth, as is everything else in our world, is logarithmic. In the northern hemispheres, it's fairly static. In the southern hemispheres, it continues to be logarithmic. So this last year, we passed 8 billion people on our planet, 8 billion people. And we currently have 4 births for every 2 deaths. So you can tell the population growth is significant, with 140 million births per year. And in the past 2 decades, we've seen a decline in childhood mortality, age 5 and under, down from 12 million a year to 5 million a year. So 60% decline in childhood mortality worldwide, which means that if we have 3,000 fellowship-trained pediatric neurosurgeons in our world, that's about 46,000 new patients per pediatric neurosurgeon per year. So, and when you stop to think that it takes a decade, 7 years of residency, 4 years of medical school, a year or two of fellowship, to get another pediatric neurosurgeon out there, it makes you wonder how we're going to keep up with them all. So in 2015, the World Health Organization gave us the Sustainable Development Goals, and SDG number 3 is related to healthcare. And things that they recommended is that by 2030, we reduce death from motor vehicle accidents by 50%, universal access to care, increased capacity for training, the throughput of physicians worldwide, et cetera. And so the other thing that came out in 2015 is the Lancet Commission's report on surgery. Jim Kim was the president of the World Bank at that time, and unbelievably, an infectious disease doctor presiding over the World Bank called for this study to be done, which demonstrated that of the 7 billion people at that time, 5 billion had no access to safe, affordable surgery. 9 out of 10 people in developing countries have no access to life-saving or disability-averting surgery, and estimated that 143 million additional surgical procedures were needed per year to meet the need at that time, concluding that surgery was an indispensable healthcare need. And so at that time, we had about 50,000 neurosurgeons in the world. As of last week, I'm told we're up to about 73,000, and here's how they're spread out. We have a disparity in that the majority of trained specialists live in high-income countries and in large cities, so there's relative disproportion of care in rural areas in particular. The average neurosurgeon can comfortably do between 200 and 250 cases per year. Primarily, that's traumatic brain injury, followed by stroke, tumor, hydrocephalus spina bifida, congenital conditions, and epilepsy. But estimated that 22 million patients with neurological disorders could benefit from consultations each year. So our first pediatric neurosurgical society was the European Society in '67, and then from there you can see that we've got pediatric neurosurgery subspecialization in every continent except Africa, and we had an organizational meeting in December in Cape Town to also develop a pediatric section of the African Association, so they should be coming along shortly. And you can see here the increase in the availability of neurosurgeons in sub-Saharan Africa over the last 20 years. We've gone from 1 neurosurgeon for 16 million people to 1 for 1.3 million. In our country, we have 1 neurosurgeon for 100,000 people, to put that in perspective. So from the World Health Organization's perspective, worldwide, the number 1 cause of death is accidents and injuries, and there are about almost 70 million traumatic brain injuries per year. 80% of those patients will recover without requiring surgical intervention. Not to say that they may be normal afterwards, but they do survive. Accounts for 9% of the world's deaths, and the global unmet need for neurosurgery related to TBI is estimated at 2 million cases per year. Now, this is from the New England Journal a couple of years ago now, but it shows that over the last 2 decades in the United States, we've succeeded in reducing the death from traumatic brain injury in our country by 50%, which is laudable. I will point out that there's been an uptick the year after this came out in 2021. We had 42,000 deaths, which was a 16% increase over what you see here. The unfortunate social commentary is that today in our country, traumatic brain injury is the number 2 cause of death, with the number 1 cause of death in adults being drug overdose, the number 1 cause of death in children being gunshot wound. We need to change that. So at the World Health Organization level, and at the international society level, we've now started an international registry for traumatic brain injury so that we can see worldwide what we can do to diminish traumatic brain injury. And I'll tell you that in Norway and Finland last year, they had 0 deaths from traumatic brain injury in their countries, so it is doable. We just need to put down our cell phones. The number 2 cause of death in children is cancer, and historically leukemia, acute leukemia, is number 1. In the last 2 decades, 85 to 90% of children with leukemia are curable, and so now the number 1 cause of death from cancer in children is a brain tumor. And that has led to an initiative through St. Jude working with the World Health Organization to develop what's been called the Global Initiative on Childhood Cancer. It's this resolution number that's too small for me to see from here, but in 2018, this resolution, the Global Initiative for Childhood Cancer, GICC, proposed setting a target by 2030 to reduce cancer deaths in children worldwide by 50%, which would estimate over 1 million children saved. There are about 400,000 children per year diagnosed with cancer. In developing countries, the majority die without being diagnosed. So the WHO has identified 6 index cancers that are highly curable with proven therapies prevalent in all countries. And the one that we're interested in is the low-grade glioma, commonly presenting with seizures, commonly living with intractable seizures, but also highly curable. So the statistics are that 80% of children with cancer should survive in high-income countries. In developing countries, that number is 20%. 80% of the cancers occur in low and middle-income countries, and 90% of the cancer deaths occur in those countries. A great healthcare disparity. And worldwide, 43% of children with cancer will go undiagnosed. That's 3% in the United States, but it's over 50% in Western Africa. And you can see a logarithmic difference in the survival rates of children with cancer between those 2 continents. So the other thing we're seeing is a transformation from the subjectivity of what a pathologist sees when he looks through a microscope to the objectivity of methylation arrays, genetic testing, which is more prognostic and more valuable than the subjectivity of what a pathologist thinks he sees when he looks down a microscope. A word on spina bifida and hydrocephalus. It's been 30 years since we had class 1 evidence that folic acid before conception can reduce spina bifida by over 70%. 30 years, class 1 evidence. And keep in mind that, at least in our series, 25% of the children with spina bifida have epilepsy. So it's an important cause. So it's interesting that even though that class 1 evidence 30 years ago came out of the UK, it was just 2 years ago that the UK adopted global fortification in their country for folic acid. This is a paper from Ethiopia, 200 million people, just under 100 neurosurgeons in their country. They have over 10,000 spina bifida babies born per year in their country. Talking to the neurosurgeons there, they said, Dr. Boop, we run 2 ORs on Saturday, 2 ORs on Sunday. We close 10 to 20 milos per day, just trying to keep up with this. And you can see that if folic acid were implemented, the diagram would suggest that this number would drop to about 15%, 1,500 cases per day, much more manageable. And this is a group of us, this GAPSBIF is the Global Alliance for Prevention of Spina Bifida Folic Acid Sedative, started by Jeff Blount, Gail Rousseau, but we've been to the World Health Assembly the last 2 years, and this last year we're able to get a unanimous vote in favor of universal fortification of folic acid worldwide in the diet. And this is going to be huge. There are over 250,000 children in our world born with spina bifida per year. So just to look at what's happened at the World Health Assembly, so the World Health Organization has representatives from 160 countries. The World Health Assembly is where all the work happens and the resolutions are debated and passed. What's happened in epilepsy in the last decade? Well, 6820 came through in 2015. Strengthen effective leadership and governance to address the specific needs of people with epilepsy, introduce and implement national healthcare plans for action, integrate epilepsy management into primary care, improve accessibility and promote affordability of drugs, ensure public awareness and education about epilepsy. Let's do away with demonic possession, that sort of thing, and invest in epilepsy research. Recognize that when the World Health Organization passes a resolution, then somebody else has to implement that, and that's typically done by the ministers of health of the various countries involved, and they have to report back to the World Health Assembly on progress that they've made, but it doesn't necessarily mean that that resolution will be a priority in any given country. So in 2020, the World Health Organization debated and passed this resolution to develop, in consultation with member states in full collaboration of the United Nations, to elevate non-state actors, a 10-year intersectorial global action plan on epilepsy. And then they go on to say they want progress reports routinely to come back to the World Health Assembly, showing that they've made progress in countries around the world. And then this final resolution in 2022, which merely calls for adopting a standardization of medical devices so that we know what we're dealing with when somebody says they're selling us a vagus nerve stimulator or deep brain stimulator. So, in conclusion, rapid advances in understanding of epilepsy in the brain have led to tremendous changes and approaches in the last century. We'll hear some of those today. Globalization has allowed advanced care for epilepsy patients to move beyond select academic institutions. We're seeing people doing epilepsy surgery in all countries of the world at different levels, and they would all love to have laser ablation and things that we have in this country that they don't have, but they're doing wonderful work. So neurologists and neurosurgeons must be involved at leadership levels in advocating for those diseases that we're experts in. It's the only way that we'll make progress there. And we're going to continue to struggle at the intersection of new and expensive technologies versus their applications to patients in developing countries. Thank you very much.
Amazing. That's all I can say. So we have time for 2 questions. When you're going to ask the questions, please come up to the mic. That was so well done and overarching. Not quite sure how many questions we'll have, but let's see.
You're kind. How about Townes Van Zant's second most popular song?
Please.
I can just yell. That's really amazing, the amount of work we've done. I think that one of the questions that I get asked that I don't always have a good answer for from some of the young people coming up, the trainees, of if I want to get involved in helping in global neurosurgery or global epilepsy or whatever, what is the best path to go through? So for those people, what would your recommendation be?
Yeah, it's interesting. If you look at surveys of medical students in the United States, 2/3 of them will say that they would like to have more teaching on global healthcare, and in Europe it's over 90%. So I think global medicine has come into its own, and we're starting to see opportunities for people to do electives in developing countries as part of their training. You can't count any of those cases for credit in your ABNS application anyway yet, but it's invaluable. I can tell you the time I spent at Queen Square was fabulous. I sent all my residents to Bristol, England, and they worked in this government-run healthcare system where You can't just do anything you want. You can't order any test you want. You live within constraints for cost. And there are more and more that are going to developing countries where, great example is because we implemented folic acid supplementation in the mid-90s in the United States, we don't have enough spina bifida for our fellows to feel comfortable closing a myelomeningocele. For the last several years, we've sent our fellows to Africa for 2 weeks, and in 2 weeks they'll do 20 or 30 myelomeningocele repairs and come back very comfortable with taking care of those children. So, I think as we look at global exchange, everybody in a developing country wants to come to the U.S. and see what training is like here. They're knocking on the door every day. But I think that exchange needs to go both ways. There are tremendous opportunities for our people to benefit from spending time in developing countries as part of their training. It'll change their whole worldview when they get told they can't get an MRI for 6 hours. My friends in the Philippines can't get one for a month.
Great talk, Rick. Really, it's thought-provoking on many levels. I thought about my own experience, was meager with Sandy in going to Africa and operating, and I don't. In retrospect, I'm pretty sure I really didn't contribute much. Maybe I gave the guys there a week of vacation, but I think the problem is bigger than doctors. It's an economic issue. The guys that I was helping, I didn't really contribute much talent to them. I mean, I didn't teach them anything. They're pretty good, as I mentioned talking to you before. It's not a question of training because they're really immersed neck deep in really some challenging problems with their talented people. It's the economics. After a few years of doing the right thing, they have to put food on the table in those scenarios, and they move off and do whatever they have to do in Kenya. At least that's my exposure. Where do you go with that? If it's bigger than the doctors, what?
Well, that is a real problem in many countries, and as globalization moves forward, the private healthcare sector in developing countries develops hospitals that look like yours and mine, and patients who have money or have insurance can go there, but everyone else stays at the training hospitals, and it's a real problem. The brain drain, if you would, it's a real problem. I don't have an answer. Yeah.
Once again,
Thank you.
appreciate you. Thank you once again.